Hey guys, Dr. Marshall Lemoyne with PhysioU, and welcome to the teaching table. I'm here with two DPT3 students, Chris and Cam, and today we're going to be talking about manipulations, or now kind of known as high velocity, low amplitude thrusts, right? Previously known as grade 5s, so lots of names for it. And so let's kind of start with some questions.
First, just how do you bring this up to your patient? I know some people, maybe be a little bit fearful with the high thrust manipulation, but how would you just approach the setup and discussing this with your patient?
All right. Well, I'd say as I'm going through my exam, it's not like in the top of my head I'm thinking like, oh, I'm going to cavitate this patient or I'm going to have a thrust. So it's kind of just going through the exam. And if I decide like, hey, this patient would benefit from it, I always ask if they've ever had it performed before, right? There's a study that said it was regarding thoracic spine manipulations, so the flexion extension ones, and the only adverse effect that they were able to find up that they came out with was pre-manip was someone who had a previous bad experience with a manip. So if you're worried about a thoracic manipulation with your patient, the study showed having a previous experience of a bad outcome with a thoracic manipulation was the only one out of everything else, right? So it's like, oh, so ask them, hey, have you ever had your neck cavitated before? I try not to say the word adjusted or popped or whatever. I try to use a little bit more better term. Have you ever had your neck cavitated, or to see what they say, or your lumbar, your lower back, have you had it cavitated before? And hopefully that leads to, what does that mean? Like, oh, I'm not sure what you mean. So it makes it a little bit more medically, Oh, it's where, we kind of put you through a quick stretch, and sometimes you might hear a pop in your spine or something like that. But we just kind of put a quick stretch and try to get your joint to move a little better. So that's my go-through. I try not to say the word manipulation. I try not to say the word adjustment. I may say, hey, have you ever had your neck mobilized? All right. What do you mean by that? It's like, well, we try to move some of the joints, kind of make them a little looser. Sometimes we can do it slow. Sometimes we can do like a fast one where you might hear a noise, no big deal. So I kind of, that's my lingo for them. So quick stretch, a high-speed mobilization, you may hear a noise, cavitation, right? That's because I don't want patients to think they were out of alignment and I have to readjust them back into alignment. We don't want them walking around thinking that. So, good question.
When doing a manipulation, what are the contraindications to them?
Oh, there can be a lot, right? So it depends on what body part you're going to go after. So if we think about the cervical spine, which is the one that has the most red flags and caution behind it, right? So you want to know about your D's and your N's, right? So think about your 5 Ds, 3 N's, so nystagmus, all that stuff, diplopia, double vision, drop attacks. Ask about that with patients. We think about some of the common ones that might make somebody unstable. So do they have any ligament instability? Do they have any fractures? Are they a possibility of ligament instability, meaning they have things where they've taken a lot of steroids, so asthma, chronic asthma? Are they someone who might have a risk for a fracture, so osteoporosis? So those are people that are also contraindications that I would want to worry about. People with nerve root pathology, right? So they have radiating arm pain, leg pain. They have any type of neurological reflex. We're probably not going to do any high velocity thrusts to that spine because we want to make sure we want to just play it safe, right? Now, if someone just has some numbness and tingling in their leg, right, but the reflexes are normal, myotone's normal, I have no problem performing a thrust on that patient, knowing I've checked for safety of that patient. Yeah. Good question. I would say, based on each region, there's kind of a list of ones that we'll throw up on a PowerPoint that you should be aware of, just for safety. Yep.
And with the CPRs, what's just an easy way to kind of remember those?
Well, the nice thing is because manipulation or high velocity is kind of like a hot topic, there's a lot of research that are trying to find out who would benefit best from it. And so there's kind of clinical prediction rules almost for a lot of different ones based on it. And so the most common one is the lumbar one. For a lumbo or lumbopelvic thrust, the clinical prediction rule is, again, that most common one, pain less than 16 days, so pretty acute, an FABQ of less than 19, so they're not too worried about it. One hip that has greater than 35 degrees of rotation, meaning they have good hip mobility. We PA'd and they have a hypomobile segment, and the pain is pretty localized to the back, but like it doesn't radiate past the knee, meaning we can take out any type of disc or nerve pathology, most likely. So sideline involves side up for this neutral gap, right? We're going to straighten out the lower leg, right? The top leg I'm going to put in my hip pocket, And I'm just going to kind of go through flexion and extension. And again, there are lots of different ways that people have been learned to wind up and manip. This is just kind of the one that I do, and I look for when the segment that I want to perform the technique on, the one below opens up, then that one opens up, and I stop, lock his foot. I kind of keep that there. I keep my hip there as best as I can. All right, let me relax this. Let me take your lower arm. Good. Now for here, right, I'm just going to wind him up. Ideally, it'd be nice if there was a sheet underneath him so he's not so sticky, right? Wind him up. If I let go of my leg now, his leg should stay up, right? If I wound him up enough, tension should hold this up, which it did. Let's say I let go and it fell down, it means I didn't wind him up enough. So I'm happy with this because his tension is keeping his leg up. Good. All right, so have him hold his arm. Don't use your ulnar border, that's painful on people's ribs. So kind of try to pronate to use the meaty part. Same thing here. I don't want to be like this. That's bony border. So try to get some meat of your forearm on this area. And then just kind of play with where's their tension, right? So if I wind up this, so I say, hey, you know what? There's some tension there. And I'm going to roll him underneath me. I don't want to manip with him here. Tension, keep the tension, roll him towards me. And then you think about the same thing we did with thoracic, right? Try to do like a lat lock, sit up nice and tall. Make sure there's tension. Good. Deep breath in, breathe out, follow him, and then help him out of it. Good. So if we recap, thrusts are safe if we ask the appropriate questions and do the appropriate screening, right? They're effective, right? All the prediction rules and the guidelines give them an A rating, right? So they're safe, they're effective. And then the benefit to them, right? There's lots of benefits, not only just this mobility deficit problem, but there's a lot of research that talks about just pain gating and neurological changes in terms of breakthrough of pain, improved range of motion, ability to activate muscles better. So we should use them in our practice. And the only way we're going to use them is if we become more comfortable and practice them. So practice on each other if it's safe. The long-term goal should not always be to get a cavitation, right? It's nice when we do, you kind of feel rewarded for it, but studies show that even without a cavitation, just the thrusting itself, that quick stretch, patients get benefits from it. So I hope you guys enjoyed and you learned something. Take a look at all of our social media accounts and drop us a line, give us a like, as well as go to PhysioU.com and take a look at our mentoring minutes and teaching tables. Hope all is well, guys, and we'll talk to you later. Take care.